I think they need to incorporate some stuff like this in nursing schools and medical schools. I think that there's such a taboo or stigma associated with saying I need help or I need to talk to somebody about what I just experienced or the trauma that I just went through.
I remember the first cardiac arrest I had. It was a really sad case. It was a young person died. You don't want to be that guy that brings it up and is like, hey, can we talk about that? Because your partner is like seasoned paramedic. You know, we walk away from the explosions. We don't look back, right? I think that culture has changed. Back in that day when I couldn't ask my partner, I didn't feel comfortable, like, hey man, that really sucked. I'm struggling a little bit that we just coded this 21-year-old and they died. I think the culture has changed, like you were saying. It's now become not just something that is reactionary, but like you said, preventative care, like primary care of sorts.
This episode of the Minds on the Frontline podcast explores the emotional parallels between emergency room staff and frontline workers. Today, we are joined by Dr. Keith Alangaden, an emergency physician and EMS medical director, along with Avi Amirsadri, a nurse and the ER director at Sinai-Grace Hospital in Detroit, Michigan, in downtown Detroit. Together, they discuss the shared stress, culture, and coping challenges that connect ER staff and frontline workers. From the struggle to process trauma to the importance of peer support and closure, this episode explores how human connection and a touch of dark humor can be the difference between burnout and resilience. If you've ever wondered whether ER professionals get it, this conversation makes it clear. They do. Minds on the Frontline is presented by the Frontline Strong Together 5 program, offering 24/7 mental health and crisis support for Michigan's first responders and their families. For more information on FST5, including free access to resources and how to connect, check out the episode description. And follow us on social media.
Well, good afternoon, everyone. How are we?
Good.
Well, thank you for joining us.
Thanks
We'll
for
start
having
with
us.
you, Avi. Tell everybody who you are, what you do, and where you do it.
My name's Avi. I am the ER director at Sinai-Grace Hospital. Why do I do it? I ask myself that all the time. I truly love my job. I started off as a new nurse in the ER at Sinai, worked there about 6 years, went to NP school, and then worked as a part of the hospitalist group and the rapid response team in the floors. I got a little bit bored doing that, so I said, what's more challenging than this? So I ended up working in the ER as the director. It's quite challenging, but again, I love every single second of it.
You don't know what today holds type of thing. And you know what the best part about the ER that I hear, and maybe Doc can confirm this, is that's the one part of the hospital when you leave, it just stays there, right?
Yeah.
And follows me home.
Maybe because you're the director a little bit, but if you're a doc or a nurse, you kind of do your thing and you go home, like being a fireman or a cop. But like some other parts of the hospital, they're following up on patients. They have them for weeks at a time. It's a different story.
Yeah, we equate you to like would be a detective that has to, he has that file that he has to take home and think about.
Right.
If you're,
Me and you are just two beat cops.
Yeah. I'm like, all right, well, see you later. I'm
I
going
wrote
home.
my tickets. I'm going home.
Exactly.
How about you, Doc?
Yeah, so my name's Keith Alangaden. I'm an emergency physician here at the DMC. I work at Detroit Receiving and Sinai-Grace Hospital. But I got my start as an EMT. I worked in the Downriver area, based out of Taylor, for a few years through college, and then I started med school here at Wayne State. I ended up doing my residency in emergency medicine here at Detroit Receiving. And then after that, I did my EMS fellowship at the University of Pittsburgh. So I got to experience EMS from a different side, from being a provider, now as a medical director, and that was really awesome.
I bet you that was really good experience because Pittsburgh is underrated when it comes to its progressive way of pre-hospital care. Give everybody a little insight of what it means because, in Michigan and many other states, we're good, but some states go above and beyond. And I think Pittsburgh specifically, that city within Pennsylvania, does a real good job.
Absolutely. And it's widely considered the birthplace of EMS in this country. You look at organizations like Freedom House Ambulance, which was arguably the first EMS agency in the state of Pennsylvania and then in the country. They were the first people to endotracheally intubate a patient outside of the hospital. And all that came out of Freedom House Ambulance. And so much of the research that we used to guide pre-hospital care was based out of Pittsburgh, and it came out of the group there. That whole area of Western Pennsylvania is very progressive when it comes to EMS. They are a commonwealth, and they take that to heart. So every agency is essentially, no matter how small your borough or neighborhood may be, you're entitled to create your own agency. And so there's a ton of agencies there, but they have a very robust, pre-hospital environment, predominantly ALS care. The city of Pittsburgh has a Bureau of EMS, one of the rare places that has a standalone third service municipal EMS agency, as well as a Bureau of Fire and Bureau of Police. So it's a little bit of a different environment. When I came back here, my current role, I'm Deputy Medical Director for DEMCA, Detroit East Medical Control Authority, as well as some other various EMS roles. But why I know Avi is I'm the EMS Director at Sinai-Grace Hospital as well. Many hats, but same common interest, I think, in EMS and pre-hospital care.
Yeah, and like I was talking to them in our pre-show, and maybe you'll agree with this, Scott, is that people that work in the ER, I say people, that's all of everybody in there, the techs, the nurses, even some of the transporters and even the docs and the PAs, got a little EMS in them. A little bit. Way more than any other hospital. They're a little bit part paramedic, first responder brain in a way.
They have to be. They absolutely have to be. There's no doubt about it.
And I'm saying specifically those that reside in the ER. ICU is a different thing from the psych floor, from OB and delivery. They all have their own thing and personalities, which is good. It's the human type. Now, we talked that there's all that overlap in personality type and the type of things and types of patients we like to see. There's a reason people work in the ER versus the other things they don't want to do, right? So what common challenges do you guys see both in the ER staff and the field responders that are similar when we encounter those higher acuity calls or situations that might, leave something on us?
There's so many challenges. I'd say for nurses in particular, they really have to be on their A game at all times because anybody can decompensate at any time. So they have to be a little bit high strung, and sometimes their interpersonal skills are not that great. They're kind of tunnel visioned in some ways. But I'd say knowing how to prioritize and do everything based on acuity. As challenging as it is, I think that they're really, really good at multitasking. And I think that they're really, really good at doing what needs to get done so that a patient doesn't crash on them.
Yeah, he basically described EMS in the back of a rig. Trying to
exactly
that, right?
The similarities, right? That's it.
Well, he seemed like he didn't really talk to me much. Well, he was focusing on your blood pressure and keeping you alive, and you're decompensating. So it kind of feels a lot like that.
Right.
Where you get this almost like in the moment vibe. You ever feel this where you're like so dialed in, you're working on something on behalf of the person, but you're not even talking to him like a person anymore? And you're not doing it in any type of negative way. Yeah. It's just not. It's the absence of this.
Focused on that task at hand. Yep.
Yeah.
I actually told this story a few weeks ago. When I was a nurse down there, I went in. This guy was really, really sick. I ended up putting a line on him, got the labs, put him on the monitor, did everything I had to do, got an assessment done. Everything was done within a matter of 5 minutes. The end of it, he looked at me and he's like, "You are a true ER nurse. I've never seen anything like this before." And I was kind of taken back because it also kind of hurt me that I did everything so quickly that I took that human aspect out of it.
Right.
But then I was like, well, I guess this is why I'm an ER nurse. Yep. But
and that's what I'm speaking to, right? And a lot of first responders have that show up. There's something going on. We're not walking into this delicately because we can't. Well, certain situations certainly require a delicate touch. Yeah. But at the same time, things can go sideways in a half a second.
Right. Sometimes you don't have the time or the ability to use empathy when you're dealing with something. You just got to get the job done.
Feelings into the job, that's when bad things will happen because we see so many bad things. That again,
well, in the ER, right? But like on the pediatric oncology floor, we want the most kindest, sweetest humans ever.
Exactly.
Just gracefully.
You have to be abrasive, a little abrasive, in order to do this job and to do it well. Right. Or else you're just going to let your feelings get in the way and it's going to go home with you and it's going to crush you.
Interesting.
Sounds familiar, doesn't it?
Yeah. Wow.
For all you first responders listening, does that sound familiar?
ER responders, same thing. Doc, how about you? What common things do you see in that overlap?
Yeah, I think the first thing that strikes me is there's, you were talking about the same personalities. They typically are a little bit distractible. They like shiny objects and they like that adrenaline or that excitement. I think that draws a lot of us to the field of emergency medicine and the ED and pre-hospital environment and being a first responder in general, right? You're after that. Yep. You want to help people, but you also like that flashy thing, right? I like being excited by this. I like doing this. And so it's a lot of fun. And I think that's the first thing that draws people in. I think that the overlap is very similar. Your task switching a lot, so it doesn't allow, you're being detail oriented, but then you move from one thing to the next thing super fast. And that doesn't allow for a whole lot of time to build a human connection sometimes. Our encounters are brief, right? In the pre-hospital setting, 15, 20 minutes, 30 minutes if it's a long transport. From scene to hospital.
Yeah, especially in our areas where we have hospitals everywhere.
You got, hospitals within, you can throw a rock and hit a hospital, right? So it's a short transport time, and you have a short period of time to make a very intense and profound connection with this person that is in a vulnerable situation. It's the worst day of their life, we like to say, but it doesn't allow for like you can't get into all of the feelings. And I think that's what Avi's referring to is like you need some depersonalization to some degree on both ends of the patient, but also as a provider, right? You have a job to do. And so I think you talk about the common challenges, that's a big one because like Avi said, it's protective for all of us. Like we don't want to take our, our emotions home with us, but at the same time it can, you allow that to get too far on either end and then you're not being a good provider. You're not being good to your patients.
Yeah, so you're maintaining that balance. And I look at it through coping mechanisms to keep me in my prime because I don't want to show up to somebody's house and be a jerk. I would be lying if I said once in a while at 4 a.m. when you hear a question, you answer it in a way like, that kind of sounded bad. It wasn't like super bad, right? It wasn't going at them, but like we've all had a tone in our voice that has nothing to do with the people around us.
So why are you here? Why did you call us today?
Sure, and we want to avoid that. So like in what ways do you observe your people coping? I say your people. You know who I'm talking about, the ER, because we see it in the field. We see coping can go one of two ways. You can feed the good wolf or you could feed the bad wolf, right? And it's kind of there.
I'd say for nurses in particular, they really establish deep relationships with each other. So when I was a nurse down there, I had a strong support group. Some people were very senior to me. Some people kind of started around the same time as me. Without their support and without being able to vent or lash out at them, I think I would have probably lost my mind when it came to some of the most difficult cases that I had to deal with. Unfortunately, I think a lot of people self-medicate in our fields, and it may be alcohol, it may be, who knows, drugs, whatever they choose.
You know the one I see a lot? Just eating to eat.
Yep.
Yes.
And so you get the calorie overdose. I call right. Yep. And so I'm not an alcoholic. I'm not this. I'm not that. But like you just don't stop eating because you're kind of coping with it in this negative way. How easy is that to do in private EMS?
Oh yeah.
Fire department. ER.
Yep.
Oh, they brought a big thing and it's in the nurse's room and everybody's eating cake all day.
Right.
Exactly. And when you do finally get a chance to eat after 9 hours of starving and just drinking coffee, you overeat, right?
Yeah.
Whatever they have in there. Hey, has anybody go to Taco Bell?
Right.
Yeah. If you are, get me 12 tacos.
Food, right?
I'd like 12 tacos, please.
Right.
Yes.
No, we see the nurses all the time. We interact with them more than we do the physicians. We still have great relationships with our physicians. But give us a little insight of what's going on behind the glass where the docs are in that other spot, like looking at their tablets or whatever they're doing.
It's a lot of dark humor. I think that's a coping mechanism that sometimes it is a way of finding something funny in a tragic situation sometimes. And, sometimes to the average person, you hear that and you're like, I cannot believe those words came out of your mouth right out of the context. But in some ways, it's just, it's something that I think is our way of processing these difficult situations and emotions. And the one thing I loved about, being in the pre-hospital setting and then, being a provider and then now being in the emergency department, it's this team mentality. We're in the trenches together. We're dealing with the same difficult patients, challenging patients, traumatic situations. There's a real reliance on each other, I think. Not just that peer support that gets called in when there's like a tragic event or something. It's literally the person next to you that is like, hey, that looked pretty bad. Let's joke about it. Let's talk about it. And it's those quick kind of like not really structured interactions, but really, conversations that
you're leaning on each other almost.
Absolutely.
Like that other person like you talk about the same common things all the time.
Absolutely.
And we got those people we know at work like, oh man, I look forward to watching him be funny today. Or whatever. Whatever it is. Like, this is gonna be great. He's gonna have a good one-liner about this. It's gonna be so fun.
It's when I start seeing the vein in Avi's forehead start popping out.
That's huge, isn't it? It's
and
like
you talk about the dark humor.
Yeah.
And obviously that's very, very common thing with all first responders also. So have you been to the incident where you're at the family event, Thanksgiving, and you say what you think is the absolute funniest thing in the world?
It falls completely
except for the one other doctor in the corner who's now laughing his butt off, and his wife, that's not funny. That's not funny.
You're not at work, honey.
So it happens in every environment with all of us. Yes.
Yeah.
And I think that's why we find, well, first of all, that's why a lot of firefighters and EMS marry nurses.
Yeah.
Because there's a lot of that personality overlap. There's a huge understanding of what each other do. And sometimes that could be good, sometimes that could be bad. But we also see a lot of commonality in just the social environment. Those two groups always end up with each other in social environments all the time. It's the human type. It really is.
Yes. Law enforcement is marry either nurses or teachers seems to be the common
thing.
Or probably dancers who maybe future nurses. I don't know how that works, but
they're all future.
Yes.
Something. So let's talk about those coping skills. Like we said, there are good ones, there are bad ones, and everybody has their own. And I think humor is a great way. I think just connecting with the people around you, talking about, can you believe Mrs. Smith is back? She comes in here every week. And just kind of like saying that, you're getting it out with each other without their daughter hearing you or whoever, right? But what about the inability to process that? Some people bottle that up and they just go to the next patient and the next patient, and they don't even know. So what are those challenging calls? How do they contribute to that burnout and not letting it out?
I think coping is one of the things that we don't do very well. It takes a pretty well-rounded person to be able to cope with some of the stuff that we deal with and see. The field in the ER, or being a paramedic or a physician, I'd say in particular, it's all consuming at times. So I don't really know many people who can just go home and turn the switch off. So it's going to just continue with them throughout their day, which again, I think is why a lot of us have friends outside of the field.
We have less of them.
If we do, they just don't get it.
We've all known them
I thought you
for
were
5.
going to say, just don't have friends, full stop.
Period.
Yeah.
And do you find that the friends that you have that are outside of the field, they always want to ask you questions about, and that's the last thing you want to do is talk about, I don't want to talk about doctor stuff. I don't want to talk about firemen.
Unless it's funny.
Stuff. Well,
It's funny,
but that's
But as soon as you tell somebody what you do,
it's not funny.
Oh, that must be interesting.
Yeah.
Tell me about X.
Yes, I love the fact when this is Avi. She's my friend, the ER nurse. Or this is my
don't
friend,
introduce
my
me as
friend
that.
Jeff. He's a fireman. This is my friend Scott. He's a cop.
Yeah.
How can I just be your friend Scott? Do I have to be that? You know?
Yeah. But coping is definitely difficult, I think, for a lot of people. You have to be pretty well-rounded in order to cope with some of the stuff that we see. But again, it boils down to having a support group. And I think the people you work with are large, your biggest support group. And then hopefully you have somebody to go home to, whether it's family, friends, wife, husband, kids, talking to them as much as you possibly can, because sometimes people don't really want to let it out. So I think a lot of people just end up bottling it up, and it's going to show in their daily lives. It's going to show how they interact with other staff members. It's going to show how they interact with their patients, and it's kind of like a trickle-down effect until you combust. So finding those coping mechanisms, I think, is so, so important. I don't know that many ER nurses, maybe they do, but I don't know that many who are into the whole being mindful, meditating, yoga, exercises, breathing exercises. If they did do stuff like that, I think their lives would be so much better. so much better.
We talk about this on the show a lot.
Yeah.
Yoga mats have found their way into the fire, law enforcement. They found it like as a way of training now. And if you did that when I started, they'd be like, I mean, you'd get called all sorts of names we're not allowed to say anymore. But like, you're seeing a huge trend towards that, and it's nice to kind of feel like these tactical athlete mindsets is kind of tricking us into just breathing.
And the resistance is ridiculous because we've been doing in law enforcement tactical breathing for 100 years. Get that tunnel vision out. Get the blood back to
slow it down.
Excuse me. Yeah. Now we go, okay, but now we can teach you to relax by breathing. We can teach you to. I'm not doing that.
You got to make it cool. Like, tactical.
You got to tell everybody it's performance enhancement.
Just change the name.
Take time off your mile time.
Just change the names. Change the names.
So what do you think, Doc? Not processing that. How are you seeing it manifested from your point of view?
It may not be anything big, right? It's these micro traumas, like you have an unpleasant interaction with a patient, right? That can ruin your day, especially if that person, you got to go back and, I got to discharge this person that yelled at me the last time. I'm going to give them their stuff and they're going to throw it in my face. Like, those things, they add up, right? And then, like Avi was saying, it's really hard, after a shift, especially at the end of like 8-9 hours of seeing patients, and you're just like kind of at the end of your wits, and you got to go home and like, all right, well, I got to get up and do it again tomorrow, but I can't fall asleep right now. It's going to take like an hour and a half to like, I got to eat, wash out all the caffeine I've been consuming over the past shift.
Another coping mechanism.
Yeah, exactly, right?
How many Zins are in a day?
Exactly.
How many taking a smoke break?
How many did I have? 2 or 3? And
6 monsters later.
How many Celsius? Et cetera. So it's one of those things. I think that Avi touched on a couple of things. Like being mindful is something that we're trying to incorporate a little bit more. Coming from a physician perspective, you're supposed to be, the buck stops with you, right? And that mentality kind of pervades. Like, doc said I had to do this, right? And ultimately, you feel responsible for, not only the patient, but everybody that encounters that patient, the nursing staff, et cetera. And so whether it's true or not, whether it's deserved, like that R word that's become kind of a dirty word, like resilient, being resilient to that has been, I think, abused during the pandemic. And so now, like,
I like gritty.
Gritty is a better word, I think, is like, it speaks to, you're not making up for those systemic challenges, but it's something that is internal to you, that you have a little bit of grit.
Deep roots can't knock down this tree kind of thing.
Can't knock down this tree. But yeah, I think for me, at least, you know, one thing I've started doing is I get nervous. So I'm being on the spot, right? And sometimes if you're doing a procedure or you're in a bad trauma or code, or, you know, there's someone that is really depending on you.
And you're the expert in the room.
You're the quote unquote expert, right?
You are the 911 in this situation. You're nobody else to call.
And being like, you know, sometimes the youngest person in the room. There are people that have like been doing this longer than I've been alive, but somehow I have these 2 initials after my name that make me in charge, right? It's kind of this wacky kind of mindset sometimes, and it takes a second. And what I've started doing is, you know, taking a deep breath. That concept of like a stacked breath, right? So blow out as much as you can, then suck it in, and then take a little bit extra, and it like can center you again. It takes 2 seconds. You can do it behind a mask, right? No one sees you when you do it, right? Yeah. Like, what are you box breathing for? Or what are you doing this like tactical breath or sniper breathing or whatever? But it takes a second, and that's, you know, just one way on shift that I'll do that. But at home, you know, you bottle this stuff up, and I think you guys can, you know, attest to this, and you've seen it in your colleagues. Like, that person that never talks about it, that never jokes about it, that just like takes it home, they explode. You can only, you know, handle so much before the top
it's the
blows
quiet
off, so.
one that you got to worry about.
The quiet.
The guy complaining is getting it out.
Oh, yeah.
He might be annoying, but he's getting it out.
Just fine.
He can live forever.
Probably will, yeah.
So let me ask you guys this. In the first responder world, there's a time period that starting around 7 years, they can go as long as 15 years, where you see this person kind of go inward a little bit. They're angrier. They're not content. And it doesn't matter if they're busy, not busy department, but they achieve an expert level after about 7 years of doing it professionally. And you know it. You know the system. You have a very good, mature look at it. But then you feel powerless. And this goes for those people who don't have an opportunity for advancement or anything like that, where they're doing the exact same thing they've been doing for 7 years.
Groundhog Day.
Exactly.
Yeah.
And they get that mentality. And I could picture ER docs and nurses feeling like that. Do you guys see that in the same, maybe not the same timeline, but almost like they're in that spot?
I think it depends on the individual. There are some nurses that have been doing this for 15, 20 plus years that I know that are still in the ER at Sinai, that because the ER is so dynamic and it changes every single second, you're always going to see something new or learn something new or interact with somebody that's going to change you or make you think. It really, I think, is a little bit more complicated than that. It depends on the person that we're talking about.
Maybe express that it's not for everybody, but it's a trend that you could see in some people in certain situations that maybe don't embrace those challenges.
It's when you develop that cynicism.
Yeah.
That's kind of
where they become jaded for sure.
That's where I'm kind of
They do become jaded for sure. I can for sure say that I became jaded after about 5 or 6 years of doing it. I thought to myself, I hit my cap. But I did have a fantastic mentor that she still mentors me to this day. And I cringe when she calls me boss, but really she taught me everything I know. And I always go back to some of the things that she says. This field and why we choose to do what we do, it can really, really impact and change a human being's life. So I always try to go back to that. Now, whether or not other people think like that, I don't think so. I think a lot of people do become jaded. I think they do become a little bit resistant and then kind of become bah humbug about a lot of things.
Eeyore.
Yep.
Yeah.
They go Eeyore, I call it.
Every contact you have, somebody's having a bad day.
Yes.
Exactly.
No one ever goes, you know what? I'm going to go to breakfast and then maybe do some shopping. Just stop by the ER, see how they're doing.
Yeah, you just say hi, right? No one calls me just to say hi.
Right. So they're already in a bad disposition.
Yeah.
And you're dealing with that negativity just as we are. Nobody ever says, I think I'm going to start my kitchen on fire because I want to see those handsome men on the big red truck.
Right.
Or I'm going to drive 110 miles an hour down this subdivision.
Just so a cop pulls me over.
Yeah, that's just what
I like those guys. They're so nice.
She used to always tell me, Avi, whoever is your patient, this may be, we always go back to this, their worst day of their life.
Right.
So you got to give people grace. Just because they're being terrible towards you doesn't mean that that's who they are. They are having a really bad day, whether it's a family member, it's a patient. We always have to go back to this is a human being, and we have to treat them with dignity, regardless of how they're treating us. Again, that's much easier said than done for a lot of people, but I always have her in the back of my mind. I have a few people in the back of my mind that when I'm about to lash out or when I'm about to pop, I always go back to
Feed the good
them.
wolf. Feed the good wolf.
Right.
Sometimes they win and sometimes they
Well,
don't.
that's the thing. Is
You're human.
Dignity and empathy are important for every aspect, for everything. But there are times that you're a human being.
Yeah.
Yep.
You can't do it. And then, afterwards you're like, I didn't handle that well.
Yeah.
I did not.
You just hope your boss looks at it like a teaching moment, maybe.
I could have done better.
So I think that kind of addresses the need for good coping skills.
Yeah.
Is mindfulness, grittiness, and resilience comes from the point of like maybe just not being strong enough to handle something, but being smart enough to not, like, that doesn't even matter, and letting it pass by. And I think it was like, I don't know, when you mature as an adult, you kind of get to this point where you stop caring what people think, especially about you. And it makes your day so much less stressful.
You're like,
it's kind of like that, like, whatever, moving on. Like, and you can move on to the next thing. So I think that kind of just speaks from maybe not an educational point of view, but human to human. I think we can all recognize that this jaded thing can happen in all of these careers, high stress. We're so passionate about it, which makes us upset when things aren't being molded in a certain way. You doing the same thing all the time, and you just got to be reminded. And I'll just, before we go to the next topic, one of the best things I ever heard was Dr. Arash Javanbach sitting in that chair and telling us sometimes your compass falls out of your pocket, and you got to knock the mud off. You got to clean off and remind yourself where that compass was leading you and why you were headed in that direction. And so I've been reminding myself that at the 3 a.m. call for the patient who's got no problems but doesn't, whatever's going on. Yeah. I'm reminding myself in the big picture of that all the time. And that's more of my mindfulness to keep me from going down that road of shooting my mouth in the wrong, whatever it is, right? So we're all human. It is what it is.
Absolutely.
So let's, one of the things I want to talk about is the healthcare continuum of a patient and the fact that bad calls or situations, whatever they are, and between all of our experiences, we just had a bunch of flashes in our head. Yeah. The common theme is from the 911 dispatcher that took the call, the fire, EMS, and police that may have interacted with those people on scene, to the paramedics and EMS providers that transport the patient to the hospital, and even the corrections officers that are bringing their sick and injured to the hospital. We are all affected in some way, the same way when you take over and care for them, their situation is bleeding over onto you, pun intended. So why is it important for first responders and ER staff to be aware of patient outcomes? What happened for that closure, right?
From a closure standpoint, you talk about the dispatcher. We were talking about this earlier. It's the dispatcher that is taking that 911 call, right? They're getting the raw, unedited, just pure emotions that caller is giving, that the screaming, the yelling, the chaos that they can hear in the background, right? They're getting that, and they're trying to sort it out. And so sometimes I feel they have the hardest job in all of this is because they have to triage that initial phone call and make sense of it. And the emotional strain on that is just unbelievable. They don't ever find out what happens after the fact, right? So that could be the most chaotic scene, but maybe that person that was in that distress moment had a good outcome, right? Something positive came of them. And they don't get that feedback. And then EMS shows up, gets there. They have, they're actually seeing it instead of hearing it, which is different. And they may get some feedback. When they get to the hospital, maybe they drop the patient off. Maybe it's a cardiac arrest.
And maybe just because they know the nurse and you came back 3 calls later, hey, your buddy's doing fine.
Yeah, whatever happened to that patient.
But if I didn't bring a patient, I wouldn't have known,
No,
right?
not at all. And that's the crazy part. And then even for us, sometimes in the ED, right, we're the gateway to the rest of the hospital for so many patients, right? We admit them, and unless you follow up on that patient, they disappear from your ER eventually. Maybe not immediately, but if the patient goes to the ICU, if you don't follow up on what happened, they woke up after, being cooled after their cardiac arrest. They had a great outcome. They got discharged to a rehab or something. And unless you go back and look that up,
you're too busy going to the next patient.
Exactly.
I have someone else to figure.
Yeah, it takes time.
But it is nice that you can look it up, though.
Correct.
And I think in my system, I can't. Some can. It's a great system. You can go in and look what happened to the patient.
You get the back end.
I can just look it up, and then I can use it as training. So not only am I checking off 2 blocks, hey, remember that person we transported? Here's what it actually was. Let's learn from that. Yeah. And here's the end of story. And we're taking that little piece of paper that went in that backpack or that little rock that went in the backpack. We're taking that out.
Absolutely.
It went in, it came back out.
And that's exactly it. That closure gives you some peace about the whole situation. And also, you're talking about it from a learning perspective. That is like, hey, I did something really good on that call. I'm going to reinforce good behavior, right? Or, we messed that up. We could have done a way better job in that resuscitation.
We missed a bleed.
We totally missed this. Yeah. And so it's both like, from an emotional standpoint, it's not an open door that's in the back of my head. Like, what if, whatever became of that situation, it's closed. It's, what's behind it, right? And then the second thing is that from a learning standpoint, there's a whole host of evidence shows that looking at outcomes guides like better provision of care.
And if those outcomes were with all these reference frames you already have in your head in the situation, what it looked like, what it smelled like, all the different things, man, what a better
it's hugely
hammer
reinforcing.
That. Yeah. So ER director, what are you doing to follow up with those agencies that had the same interaction?
So I'd say at Sinai-Grace, I can't speak for anywhere else, but I'd say at Sinai-Grace, we have really close relationships with our EMS providers. So a lot of times they'll come in and if they bring somebody to our resuscitation bay, they'll kind of watch and ask questions. And our doctors are excellent. So they'll sit there and teach them or say, this is what we're thinking. And they'll have this just dialogue going back and forth. And a lot of them really want to know what's going on, why this is happening, and whatever questions they have. Sometimes they have to leave, but they oftentimes come back. And I know that they'll ask the nurses at our stretcher triage area or one of the nurses that are on trauma, hey, what happened to so-and-so? Did everything pan out okay? And they'll have that dialogue. We all went to a bunch of the firehouses and the
EMS stations just surrounding the catchment area of the hospital.
Yep, and we tried to basically foster relationships with them so that they know that they can come to us. So they have our contact information. He was really good about saying, listen, if there's any patient outcomes you guys want to know about, just shoot me an email and I will follow up with you guys. And I think that really hit home with a lot of them because one thing that they all unanimously said is we lose track of the patients and we always want to know the outcome, whether it's a STEMI or a stroke or a cardiac arrest. We're really, really good about following up with them. So just developing these strong relationships because their jobs are just so difficult.
Yeah, and it shouldn't be so sterile as I just send emails. It should be like, no, you reach out to me anytime and I'll fire one back to you. I've even got to the point now where I've asked so many times, I'm texting ER directors and they're texting me. But we built a relationship.
Exactly.
And what better way, like you're saying, is establish a relationship with the agencies so the humans can connect on behalf of the other humans.
That's key. I think that's one thing that, Avi really touched on is fostering those relationships because the last thing no one wants to hear from their doctor or their medical director or the MCA, right? I only hear about that when I'm in trouble, right? I got written up for something and I got to, sit in front of PSRO and get I got to answer.
Could have avoided that by just having strong
nobody wants to go to the principal's office.
Nobody wants exactly. And so the only time they talk to me is when I'm in trouble, right? So what I try and do is really encourage, the dialogue, right? That communication. Come to me if you have a question about follow-up, you got a question about why were we doing that versus this, right? Or if you just want to know how a patient turned out, or if you just want to say hi, like that's one of the things I think you destigmatize that relationship a little bit, and then people are, it improves care and improves relationships and all across the board, not just for that,
I like when the docs come right up and like, hey, what's going on? Like, they want
I want to hear from you,
exactly. And the nurse is there too. It's not like you're ignoring the note-taking person at the time, but they're like dialogue with you. And that's when I find the best interaction on the patient's behalf.
Absolutely.
Is when we're all got it's like family style eating, right? We're just kind of all in on it. There, we're all like just talking. It's like family style treatment, I guess.
Yeah.
We had a EMT that actually dropped off a patient last week, I think. It was a really, really busy day, but he was giving like a really long report. And Dr. Berwick was the physician at the time. We both listened to him, and I was actually doing the recess myself as the director. Good times. Once he was done, he looked at both of us and said, was that good? Was that a good report? And I looked at him, and I'm like, you don't hear that very often. But I was like, that's excellent. I love this. I'm like, are you new? And he said, no, actually, I'm not. But I always think I can get better. Is there anything else I could have said or worked on? And Dr. Berwick also looked at him kind of like stunned. And we both were like, no, man, you did a great job.
Could you teach the rest of the people you work with?
Thank you for the information.
You maybe could have helped with compressions. I'm sweating a little bit. You could talk and push at the same time.
But they definitely, I found that they definitely want feedback and they want to learn and they want to hear if they need to improve on anything or what they did well. So we always try to give them that in the ER at Sinai.
That's awesome.
That's fantastic.
This has been a good discussion. I just got some overall questions to kind of close this out. What inspires you guys about the future of mental health in emergency care systems? Because we've all seen this huge trend in the last 5 years-ish, like huge trend into mental health being truly something for everybody. Mental health is a thing. You don't have to be mentally sick to seek health care. Right. It's not sick care, it's health care. And we're seeing that in all forms of health.
I think everybody needs a therapist or a psychiatrist.
Right
I think they
Says
really
the daughter
do.
of a psychiatrist.
Except for me, because I lived with one my entire life. But I really do. I think everybody would benefit from it. I think especially in our field, it's so important to have a safe space, to have somebody that has an unbiased opinion towards what you're going through, to be able to kind of talk you through things and just listen to you.
Right.
But again, it's kind of hard to find that person. I know somebody who said it could take months to get an appointment sometimes. So having resources and knowing the right people and having that available to staff, I think is so, so important. And I don't think we do a good enough job doing that within the healthcare system in general. I think being able to just click on something or know, like, I can go to this website or I can talk to this person and I can get in to see somebody would be so, so helpful.
Somebody who gets you.
Somebody
Right.
who gets you, yeah.
Yeah, and then you could just say, nah, and move on to the next one, like speed dating almost.
Exactly, because it's not always a good fit.
Ding.
No,
Yeah, it's not
and they
always
might
a
not
good
like
fit.
you.
Yeah, exactly.
Could
Right.
you imagine? Sometimes I think about clinicians, therapists, and be like, I wonder how many of the patients they just don't like that they have to help, because we don't always like the people we care for. Sometimes they say mean things and all that.
Right.
Like, gosh, this is a bad person.
Yeah.
Yeah.
No, I'm just thrilled that we're talking about this at all. And I'm so grateful for you guys as well. This whole concept of mental health being important. And like you said, preventative care, that was something, like when I started as an EMT, and it wasn't that long ago, so I can't claim that. But I remember the first cardiac arrest I had, and it was such a cool thing, right? You're a basic EMT and you're working with a paramedic, and we were alt staffing in those days. And it was a really sad case. It was a young person, died from overdose, and didn't get resuscitated in time. But you don't want to be that guy that brings it up and is like, hey, can we talk about that? Because your partner is like a seasoned paramedic. We walk away from the explosions. We don't look back, right?
Right.
And that was that mentality. And I think that culture has changed, where back in that day when I couldn't ask my partner, I didn't feel comfortable, like, hey, man, that really sucked. I'm struggling a little bit. That we just coded this 21-year-old and they died.
Or
right?
even just knowing a way to bring it up to where you're both working through it without even saying that.
Without even talking about it, right? So, and I think the culture has changed, like you were saying. It's now become not just something that is reactionary, but like you said, preventative care, like primary care of sorts. I think everybody should talk about it.
The best part about the dinner table in a firehouse or even an EMS agency that has a full-time house. That's the best part. You're sitting there talking
about it.
There's nothing more human than sitting in a circle, talking and eating food.
Breaking bread.
And just opening up about stuff. And next thing you know, you're talking about the Mrs. Smith call you had. But you're talking about it. You don't know you're decompressing it.
Yeah,
but
it's
you're
not even
doing
unconscious.
It, and
exactly.
all we're doing is talking to each other.
Yeah.
It's not that big a deal.
Yeah.
I think they need to incorporate some stuff like this in nursing schools and medical schools. I think that there's such a taboo or stigma associated with saying I need help or I need to talk to somebody about what I just experienced or the trauma that I just went through.
Or even just struggling with a coping mechanism you can't stop.
Eliminate the stigma before it starts.
Exactly.
Right.
So, and you had mentioned, you said you think everybody should have a dad who's a psych. I mean, sorry, have a.
Well,
no, I don't recommend that.
Okay.
Maybe you don't have one you have on staff, but
yeah.
maybe you have one available to you. You know who you're going to call when you're going to need them.
The funny part is I have my dentist's phone number in my phone.
Yeah.
Every 6
Yeah,
months I
yeah.
get my teeth cleaned regularly.
Yeah.
Every 6 months. My chiropractor, once a month I go say hi, he cracks my back.
Yeah.
My personal physician, every 6 months I go get a checkup. Why not have a therapist, a clinician that, I'm just checking in. Okay, can I come in and just talk for an hour? Let's check in. Yeah, all right. Or let's do it over the phone.
And if you need to, you follow up a couple times after that. You're working through a thing and you move on.
There's no reason not to have all that.
Yeah, because it's not until we have a bunch of bad stuff going on that we realize why we're doing that bad stuff. They're like, well, I got to quit all this stuff. It's like, well, how about we just don't do it in the beginning?
To begin with, yeah.
Right?
Exactly.
And that's that prevention practice.
Yeah.
Fire prevention works.
Yeah.
Crime prevention works.
Yeah.
It's much easier than recidivism.
We think we're really
I can't
good.
spell that, but it's easier than that.
Yeah, right. right.
Easier to say, too.
We think we're really good at compartmentalizing. I think for the most part, a lot of us think we're good at it.
Yeah, we think, I'm on the next
yeah.
one. Oh, it doesn't
Yeah.
bother me. I'm cool.
But as human beings, we can only tolerate so much.
Yeah.
I think COVID really changed the trajectory of medicine, nursing, healthcare in general. And I think more people realized what's important in life, and I'm hoping that more people sought out some help or therapy. But I think that there's a lot of people still lingering with this PTSD that's just kind of been going along with them, and they don't even know that it's there.
Right.
It's just emotional
It's
knots that
just-
they haven't
yeah.
worked out. Little
Yeah.
things in there that's preventing things or making a tension with their significant other. You see a lot of that.
And it may not even be a direct correlation, right? That's the one thing that it sneaks up on you, and it's when you least expect it that it kind of comes out. You'll be watching something, and
it's at Thanksgiving dinner.
Exactly. I was telling Avi, everybody asked because I went to Pittsburgh. They're like, "Dude, do you watch The Pit? Do you watch The Pit?" I couldn't make it. That last, I haven't watched it since. I need to go back and really kind of like dig into it. It's a really good show. But it's so good because it's so accurate. And that last scene, that flashback about COVID, it just took me completely by surprise.
Okay, I haven't seen it. I'll have to check it out.
Holy smokes. Yeah, I was like, this is something I have not processed adequately yet. And it's just a TV show. It's something that we do. But
and it wasn't even like to me, the COVID wasn't this mass death and dying that was really beating everybody. It was this constant flow of more patients that weren't even COVID situation. We just had more people, and we had less beds. We had more restrictions. So, like,
everything
do
else.
more, literally with less, but do it in a way where you can't deviate at all.
Well, you didn't have time to process anything.
And you just have to keep moving.
Yeah,
keep moving.
Unlike everybody else, we can't work from home.
Yep.
I would love to work from home. I work from home. You know what? That guy's looking pretty fast. I'm just going to mail this out.
What if cops just have Waymos with cameras on?
I know. You guys just perfect. It's
the speed camera is going to take away all of it.
It's coming. Trust me.
And we don't want that. They don't give warnings.
No, you can't see them. At least I can see them.
So, final question: do you guys have any final thoughts for those listening who might be struggling in silence?
I think ask for help. Find one person, at least one person that you think you can trust, and ask for help. Ask for guidance. Make that phone call to see a therapist. Make that phone call to see a psychiatrist, because what you're feeling is, I don't want to say abnormal, but it's something that we're all probably going through or have gone through at one point in time in our lives. And we all need some help or guidance at one point in our lives. So they just need to reach out and get it done. I mean, just stop postponing it.
Yeah.
Right. The struggle is real. But you can fix it.
It's not abnormal. It's fixable.
Yeah, and we don't want people to think that you have to be in the point of suicidal thoughts to ask for help.
No.
You could just have something bothering you in the back of your mind every day.
Yeah.
That's it.
As medical professionals, would you say that if somebody finally reaches out for help and they reach to a clinician and they're not happy with the clinician, don't give up, try again?
Yeah,
absolutely.
Keep trying.
Don't give up. Try again.
It is not a one-size-fits-all solution, I think. And that's the one thing. I think it's just taking that first step is sometimes the hardest, and feeling like you're on an island. Like, I'm the only person that's going through this. And I can promise you, I think all of us have been there on some level, right? It may not be to the same extreme, but certainly, like, it is a shared experience. You're not alone. That is something that I think we tend to think that, I'm the only person that's dealing with it. I don't want to be the one to speak up because it's probably just a me problem and not a system problem or not a us problem, right? But I think, like Avi said, taking that first step is sometimes the hardest. But once you start talking about it, you often find that it's so much easier to just keep talking about it, and that weight gets lifted a little bit. But
you realize the weight wasn't even heavy.
Exactly. And you're
the thought of working out is harder than working out.
Exactly that. Sometimes it's that anxiety of just, I think about this like with I've been bitching about my email inbox for the past little while. It's growing. The thought of just like opening that and then starting. But once you do it, it's not that bad. It just keeps going.
I'm going to get in.
Yeah.
You know what? I need to water the plant.
Yeah,
as soon as I water my cactus,
I'll redo the whole bathroom.
But it's the same thing. It's that inbox up here that it's just like, it keeps piling up. I really should do something about this. And then you finally take that first step. It's like, that wasn't as bad as I thought it was going to be. And then
I think that summarizes reaching out for healthcare in all ways very well. And it's a perfect closing. It's not that big a deal. Just ask. There's lots of experts around you and a lot of people who love you more than you'll ever know.
Absolutely.
That's the big one. So, all right. Well, it was great having you guys. Thank you so much for coming.
Thank you so much for having us.
Appreciate you.
It's been awesome.
Thank you for listening to the Minds on the Frontline podcast. We have more great content coming out soon. Please check us out on YouTube, Instagram, Facebook, X, and LinkedIn. And make sure to like and subscribe to all Minds on the Frontline podcast social media channels. Thank you, and have a great day.